Hi everybody. I've long been concerned about medical intervention of children with gender confusion. I think it's really shocking that the medical profession has been bullied into allowing this dangerous practice, when research clearly shows that left alone, most children grow out of that confusion. I happened to hear a YouTube talk from Dr. Quentin Van Meter. He's an American pediatric endocrinologist. That was a few weeks ago. Dr. Van Meter is a clinical associate professor at both Emory and Morehouse Schools of Medicine, and he actually trained at Johns Hopkins, which did much of the early work on transgender. Dr. Van Meter's talk was very brave and extremely worrying because it exposes how academic medicine has caved into the trans lobby and is allowing ideology to take priority over proper care of children. Trans medicine is now replete with lies, fraud, and unethical, dangerous medical practices. It's a total disgrace, and more people need to know about this and get active in stopping it happening. Much to my surprise, I discovered Dr. Van Meter was visiting Australia this week as the guest of the National Civic Council. We managed to arrange to video his Sydney talk earlier this week, and I was privileged to chair the Q&A afterwards. I know this is a long video, but do try to listen to it all and help me circulate it. Here's Dr. Van Meter.
Well, this is my first trip to this continent, and it started at 6:30 this morning at the airport, and it's been a marvelous day seeing Sydney. I had a beautiful tour of vistas that are all breathtaking, have observed the people, and I'm very honored to be asked to come and speak in front of you all. So thank you very much for supporting this event. So my background in transgender medicine goes all the way back to my fellowship years. As John mentioned, I was in the Navy, and the Navy paid for my medical education in part, and then trained me as a pediatrician, and then also trained me through an arrangement with Johns Hopkins Hospital in Baltimore to be a pediatric endocrinologist. And so as part of my payback, if you will, for the training, I stayed in the Navy for an additional time, so I achieved a 20-year career, servicing as a pediatrician and a pediatric endocrinologist together. So at the time that I was in my fellowship training, we had what I refer to as the three musketeers. Alfred Kinsey, who was in Indiana at the Kinsey Institute. He was an entomologist who started the institute in 1947. Not a physician, not a psychologist, but an entomologist. So he knew a lot about insects. Okay, that's his background. John Money, who was a psychologist who joined the Hopkins faculty in 1951, he trained as a clinical psychologist at Harvard, a reputable educational institution. But he also hung around Johns Hopkins because Johns Hopkins was the epicenter at the time of children with disorders of sexual differentiation. That is where their anatomical parts did not match their biologic sex, or they were a mix between, the so-called disorders of sexual differentiation. And we also were unfolding the concept of how the sex is actually physically differentiated during fetal life. And that this institution essentially laid out the pathways that hormones created these effects in utero, and the patients then came to be born sometimes with a mix-up. It's a very rare concept. So these patients came to Hopkins for evaluation to figure out what may have happened to cause that, and then subsequently to design some kind of interventional therapy to bring them back to as much function as deemed possible at the time. So Money used this group of children to essentially be a fertile playground for experimentation. And he developed what was called the Psychohormonal group at Johns Hopkins Hospital. He followed the pediatric endocrinologist, the preeminent pediatric endocrinologist in the country at the time, Dr. Lawson Wilkins, followed him around his clinics, and after a year, John Money, PhD, declared himself a pediatric endocrinologist, and those are in his own words in his biographical statement. Henry Benjamin, the third of the triumvirate, was a general medical practitioner in New York City. He spent summers in San Francisco, and no training at all in psychiatry. And these three individuals knew each other well. They were all somewhat deviant in terms of their worldview and behaviors, and I can say that because I personally knew John Money and had exposure to his philosophies as he taught us his view of life, and that included sexual interaction with children. in the case of John Money, and certainly it's documented that Alfred Kinsey did the same thing, having sexual encounters with young children and boys in particular. None of this is an accusation that can't be matched. It's all archived in records. So these three folks got together and kind of hobnobbed with each other and decided they wanted to change the landscape of human sexuality across the country. So John Money introduced the term gender as a psychological concept. Previously, to the 1960s, it pertained strictly to language. Words were either masculine or feminine in a number of languages, as in German and French there for the masculine, or feminine in German and French again. So John Money made a decision that gender applied to human beings and that the term gender identified the internal sex self as male or female. So it was a concept that he put forth that had no scientific basis. He just believed it, and he proceeded with his experimentation on patients to try to prove that as false or true. So the psychohormonal group was created at Johns Hopkins. Money, trained in Boston, was intrigued, as I said, by the study of the patients with sexual differentiation, then called hermaphrodites or pseudo-hermaphrodites. So Money joined the faculty and established protocols to interview all pediatric patients who had abnormal sexual anatomy or who had early sexual maturation. Money's adult transsexual program was an outcropping of that experience, and it's what he really wanted to do at the end of the day. He took in patients, adult patients, who believed they were born in the wrong body, and they were recruited across the country. We had no internet back in that day. So this was a relatively small group of individuals. His protocol indicated these patients had cross-dress for 2 years. No hormonal manipulation. They just had to live in their new identity. At the end of the second year, if they persisted and they were employed and they maintained their savings account of $2,000 to cover any eventual cost, at least in a symbolic way, they were treated with cross-sex hormones. And estrogen and testosterone were widely available at very low cost at that point in time. Then surgical procedures were developed by the urology and gynecology departments at Johns Hopkins and applied to adults first to remove external genitalia and create new structures that had previously not existed. These were then applied to infants and young children who had these disorders of sexual differentiation. So these infants and children were either males who were what we call undervirilized. The testosterone that they were producing was either not produced or the patient was resistant to it. And in the intrauterine environment, the genitalia did not fully develop because becoming an anatomic male is a very active process. It's not at all passive. You have to work very hard to have the hormone, the receptor, and the tissue response to create all of the male genital structures, which we know are part of the human body. So these disorders happened in the kids, and the surgical procedures were applied to them to remove ambiguous parts. And then in John Money's scientific protocols, the child was changed from their biologic sex to match what he thought would be the best outcome for them. So Money's scientific protocol, so-called, where he would say, I have an idea. Let's do this and see how things work out. This is a very scary concept. Medical castration is one of the things that he was a proponent of for adult sex offenders. So back in the day before puberty blockers were available, he went to the federal prisons and had the endocrinology staff treat the sex offenders with progesterone or Depo-Provera as a means to shut down the pituitary signaling of to the gonad. And so medical castration of male sex offenders was his first foray. He also had a system of directed interviews with pediatric patients, and we had absolute word-for-word transcription of these interviews that were part of the pediatric endocrine medical chart that we would review. And they were done back in the day before word processors. They were done with what we called onion skin paper. I don't know how many of you would remember that. It's a very thin kind of paper with carbon copies in between, so that we were able to see these reports. The originals were kept in his office, and what we found is that he and his staff taught boys with precocious puberty how to masturbate. Because at the beginning of the interviews, they would ask the boys, how frequently are you masturbating? And the 6-year-old boy would say, what's that? And then very explicitly, they would teach the boy what masturbation was and how to apply it to their own body. At the next interview, not surprisingly, these boys were masturbating 4 or 5 times a day. So it was sort of a tragic thing that we viewed as a deviant way to evaluate and treat the patient, but this was part of what John Money did. Now, the tragic case that is sort of well known around the world is the boy who was one of twin boys who had his penis accidentally burnt off during circumcision. The circumcising physician used an electrocautery device called a Bowie knife to stop a bleeding point, and in the process basically fried the entirety of the penis down to the base of the penis. So this was a genetic male who had no penis, and John Money decided there was no possible way for a penis to be reconstructed, so he essentially directed the care to take this boy's testicles out and to essentially create a vaginal pouch for this boy. And that child grew up, and the parents did not explain this to the boy or to his twin sibling, but by about age 9 or 10, the boy began having severe psychological problems. And his parents confided in him what had happened. And he said, that's what's wrong with me, is that I've known all along I'm not a girl. I know I'm a boy, and it's what I am genetically. So with the help of a urologist, they were able to release some of the scar tissue, and he then took on the role of his natal sex. And he lived through adolescence, got married, and then took his own life. Because that was essentially the case which brought John Money's program down to its knees. My own personal experience was one of the last cases I had in my fellowship of a little baby boy who came down from Buffalo by bus with his mom to Johns Hopkins to be able to be evaluated for his genitalia. He had an almost immeasurable penis, and the testicles were not in the scrotum on either side. He looked kind of externally like a female, but his chromosome analysis proved he was a boy. So we assumed from the physiology of genital development that the most likely cause for this was that his pituitary signaling hormones never developed. And so he did not have sort of the finishing off of his anatomy that happens in the 3rd trimester of pregnancy. At the beginning of the pregnancy, the baby is managed, the genitalia are essentially constructed by placental hormones from the mom, which affect the baby's testicles, create testosterone, and changes the anatomy. But if that's not finished off in the 3rd trimester by the baby's own pituitary hormones, you end up with a baby boy that has essentially a micropenis and very small testicles that may or may not even be in the scrotum. So my attending and I went through the case, and we put this child through a protocol of 6 weeks of fairly intensive stimulation therapy using human chorionic gonadotropin, which is an alternative way to get the testicles to respond, produce hormone, and then to see if his tissue could actually respond to his own testosterone. We sent the baby home and arranged for the child to return in 6 weeks at the end of the protocol. And unbeknownst to us, we were very happy because we were already having problems with John Money and his organization within Hopkins. John Money was out of town as far as we knew, and so he did not get a chance to get his hands on this patient. Unbeknownst to us, John Money had returned from his trip early and without our knowledge interviewed the patient and the mother, told the mother that we did not know what we were talking about with this hormonal stimulation program, that it would fail utterly, and that the child should go home and be reared as a female. So the mother very dutifully changed the name of her child from David to Tabitha and started putting her in a dress and announced to the family that they had a baby girl, not a baby boy. 6 weeks later, the baby returns to the clinic for us to evaluate the response, and the grandmother is with the mom at this point in time and the baby comes back in a pink dress and an eyelet bonnet named Tabitha, much to our chagrin. How did this happen? What happened? Mother explained that John Money had intervened at the last minute, interviewed them, and told her what to do. The baby had a 3.5 centimeter penis, and the scrotum was full, and the testicles were present. So it was what we expected as physicians, and we knew endocrinologically what should happen. We made our point. This was a very valid human being with a male identity, both anatomically and hormonally, and so we undid Tabitha and returned David back home to Buffalo with his mother. At that point in time, John Money was not allowed to see any of the endocrine patients without explicit permission of the chief of the Pediatric Endocrine Division. And very shortly after that, his entire operation was removed from Johns Hopkins, and he was sent away in shame. So that's who we're dealing with. This is this kind of non-scientific thought of, I have an idea, I really want it to work, let's use children, experiment on them, and let's go from there and see what happens. So essentially, this slide essentially shows what I talked about in terms of the patients with disorders of sexual differentiation. The poor outcomes of his adult patients were also very well chronicled, and the patients that he changed into women anatomically and with hormones and surgery, they played their role in adult life as a caricature of, almost as if they were Disney villains or Disney princesses as grown-ups. So they were not really functional adult females. And that was the other thing that helped Dr. Paul McHugh essentially close down the program, and John Money was sent away. Now, Paul McHugh is known because of his wonderful treatise, extensively referenced treatise on sexual identity with social and psychological circumstances as well as medical. So if we look at where what happened after John Money fell into disrepute, the transgender clinical services around the world from the 1970s to about 2006 were predominantly in Europe. The Netherlands carried on their experimentation with patients, also in Sweden. Adults with persistent gender incongruence were treated medically and surgically in those two countries. Those countries were thought to be very progressive in terms of acceptance of variations of human behavior. And so the society at large, it was very prone to not be socially directed against these people because of their personal beliefs. And in Toronto, Dr. Kenneth Zucker, who's a psychologist, treated children and adolescents evaluated in his clinic, any child who was essentially out of line with their biological sex and had difficulty with that. He coined the term gender identity disorder, and it was accepted all the way up through the diagnostic criteria, medical criteria up through version 4 as a delusional disorder, okay? And that's what his premise was. He had experience with over 560 patients over a 30-year span, and he has chronicled his experience in terms of the interventions and therapies. And his work is hailed as a phenomenal treatise to essentially say that with continued ongoing psychological therapy, these individuals will desist in terms of their transgender identity in the vast majority of patients. In Boston, Dr. Norman Spack, who had visited the Netherlands and was very intrigued with their clinical services for children, returned to the US and decided to start his own clinic in 2006. I was in the Atlanta area having retired from the Navy, and I had a patient come to me who was a son of a military family who had been transferred to the Atlanta area. And this was in 1993. And this was a boy, 13 years old, who had decided he was a female. And the parents had gone to Los Angeles and found a psychologist who ended up recommending that when they moved at the next junction for a duty station, it would be a perfect time for this boy to cross-dress as a girl and then subsequently receive hormonal treatment. So they landed in my office in Atlanta, and I had no idea what to do because there was no standard of care for this in the United States. So I called all of the senior endocrinologists, those who had trained me, and I said, help me find somebody who is a legitimate counselor who has experience with this. And nobody had an idea of anybody to send this patient to anywhere in the United States at that point in time. So this was not something where this was common and just floating beneath the surface here in the United States. It was an extremely rare circumstance for a child to persist and then ask for treatment. So in 2006, we have the Boston clinic that Dr. Norman Spack started, and that was pretty much it. Now, the Harry Benjamin Society, I bring this up because this is a group of folks that essentially modeled the concept of what Alfred Kinsey and Harry Benjamin and John Money believed in. And they created an interest group. It was primarily from Europe. And the membership requirements then and in its current iteration is that you must have an interest in transgender medicine. No degree, no training, no certification required. You apply, if you are interested in transgender medicine. And that, when you go to their website, is all that's required for membership. Now, the Harry Benjamin Society sort of disappeared, and it came back as the World Professional Association of Transgender Health, WPATH. Okay, this is the same organization, same lack of science, same lack of professional credentialing to be a membership and to create the opinions of this organization, and they are held in the highest of esteem by the transgender activist community. WPATH is not happy with the major medical literature because it shows some discrepancies that they don't like. Zucker proved that 80% of girls and 98% of boys, from children and adolescents, who will revert to their natal, biologic, sexual identity with the help of a significant counseling, and that this is something that happens because puberty happens. So puberty is very necessary for these children to heal their delusional state and come out on the other end, essentially re-identifying and losing their gender dysphoria concept and the pain and suffering, because they finally realize who they biologically are, and they come to grips with it and they accept it. So if you think of any cure that has a 98% success rate, it's pretty impressive across the field of medicine. Even the 80+% of females, that's quite significant. That would say whatever Zucker did should be the standard of care. However, the WPATH does not believe in that, and essentially railroaded Zucker and his opinions out of their bibliography, and so that he is a non-entity according to WPATH. There was also a study from Sweden. Now this is a country where there is socialized medicine, and everybody from cradle to grave is chronicled, every aspect of their life, all their immunizations, all of their childhood illnesses, all of their surgeries, all of their psychological suffering, anything that's an intervention with the medical system is kept and chronicled, and it's available for review. So they reviewed the Swedish experience, and this is a country, again, where transgenderism was accepted socially far more than any place else on earth, other than the Netherlands. And they took every one of these patients and that had gone through the medical transition after counseling and had gone through surgery, and they found out that after they had been transitioned fully, medically and surgically, after 10 years of that their suicide rate was 20 times greater than that of the general Swedish population. It's a pretty telling study that this therapy that had been done to these people in a very accepting society was dangerous and caused them to essentially take their own lives at a much higher critical rate than those who were not dealing with transgenderism. So those two studies in and of themselves essentially are the basis of medical proof with actual patients and experience that counseling these patients for their lifetime is very much worth it. Letting them go through puberty naturally is very much worth it to be able to help them come to grips and to cure themselves from their delusional state. So WPATH creates its own bibliography. Poor quality research, very small numbers of patients, studies that recruit patients from their own clinics. It's not every patient as it was in Sweden. That Swedish study is everybody, whether or not they wanted to volunteer their information or not. These are people who essentially volunteered to be part of a clinical study to express how happy they were with their transgender health. Biased recruitment of study subjects, no controls, absolutely no control kids at all in their studies. Many anecdotal case reports in small, unimportant medical journals. All of these things line their bibliography, along with other things that have nothing to do with transgender health at all. And so they have about 150 references that they essentially cut and paste and put on all of their concepts, and many of them are unrelated to transgender health. They recycle a lot of their articles. The same author will write something and do it in another journal and in another journal and another journal, and they'll count that as 3 or 4 articles on the subject, verifying that transgender is a valid concept. And as I said, citations that are marginally related. They decided to create their own peer-reviewed journal, for whatever that means, and they have now an international journal of transgender health. And by having like-minded people and nobody else critique their articles, they therefore say that their science is valid. So it is a social movement dressed in scientific clothing that, when you look at it critically under a microscope, has essentially no scientific basis at all. And then you oppose that with the scientific basis that we have from Zucker and the Swedish study and other studies since then. And you see that the imbalance is phenomenal. So that transgender affirmation therapy, medical therapy, and surgical therapy have no proven long-term benefit and are essentially a return to the days of John Money, where they have an idea, they're going to treat patients and see what happens, and then they'll look at the outcome at the end through their own lens and declare themselves winners. So interestingly, the WPATH bibliography, all of Kenneth Zucker was synonymous with the concept of gender identity disorder. If you looked in a bibliography, you do a scan of medical research articles, his name comes up over and over and over again, because he was essentially the level-headed person. And he is a person who is profoundly compassionate, very, very much in support of the lesbian and gay community in terms of the health service needs that they require. And he is absolutely and utterly, completely of a mind that gender identity disorder is a delusional disorder. So WPATH, because of their distaste for science, developed their own standards of care for transgender health prevention. They lobbied the American Psychological Association Committee, specifically in recorded purloined interviews of their session. They specifically excluded Kenneth Zucker and his opinions and left them out and came up with their guidelines. And they decided to change gender identity disorder in DMS-5 to the term gender dysphoria. The reason that they gave it a name at all is so that there would be coverage as a medical entity, that insurance and third-party payers and government entities would view this as a necessary treatment for a suffering. And so the suffering became the diagnosis, as if society created this suffering, not the internal struggle that the patients themselves have. It legitimizes transgender as a variation of normal. It blames society for the agony experienced by the patients, and it facilitates the insurance coverage. They removed every single reference written with Kenneth Zucker from their bibliography, if you look at their current bibliography. And it convinced the Canadian government to fire Zucker and to shutter his clinic. So here is the premier person who is the most compassionate, caring clinical psychologist who developed the pathway to success and healing, and they shut him down. So everybody else out there who is in the field of academic medicine or who is sponsored by a government entity lives in fear in the United States and in Canada to not open their mouth and say anything for fear that they will lose their livelihood and be shuttered, just like Kenneth Zucker was shuttered. So meanwhile, back in the United States, Norman Spack coalesced a group of adult and pediatric endocrinologists into a working committee to establish treatment guidelines for the United States' Endocrine Society. The Endocrine Society is a primarily academic group of primarily adult endocrinologists. I'm a member of that society as a pediatric endocrinologist because there's no exclusion of pediatricians. And they develop guidelines for treatment of various and sundry conditions, such as hypercholesterolemia, for testosterone replacement in adult males, for treatment of polycystic ovarian disease, a lot of very current issues in the endocrine world. They decided that they would coalesce a committee, and the committee, very coincidentally, had not one single individual with a diverse opinion. Such as Dr. Zucker's opinion or Dr. Paul McHugh's opinion. They were specifically excluded from the committee. When you look at the membership makeup, I know a lot of these people personally, and I happen to know some of their social agendas that go along with their professional and personal lifestyles. And it was amazing to see that the Endocrine Society put together guidelines based on the opinions of just these people. So, as I said, they completely, anybody with a contrary view was not kept on that committee or invited to that committee. So in 2009, they published the guidelines for treatment of transgender persons. This was hailed in this throwaway journal called Endocrine Reviews, or in the news, and this was the cover debuting the guidelines. Now, the guidelines essentially were, I think, 23 in number. They say, first of all, do a thorough psychological assessment of the patient. That's the foundation where you begin. They do admit that the person that should do this should be a person very well experienced in transgender health. Okay. Now, if you look at a group of American psychologists, there are not a lot of people who are experienced in transgender health because it didn't exist as a healthcare issue until fairly recently. So there is no training program. The training comes from seminars held by WPATH in the United States and other countries. And it's a 2-day affair, and they all talk together about what they like to do, and they come out with a training certificate. And that's the extent of the expertise that's required. So it says do a psychological assessment, but it's what in truth in our country is that what that is an assessment of what the child feels, and then essentially working with the family to make the family accept and affirm this child in this new identity. And so they are told, the children are told that any child that says they're born into the wrong body essentially is affirmed. That's what happens. Then the next step is to block puberty as it begins, not before it begins, but once there's signs of physical changes that we know and identify as puberty, puberty is to be blocked, as if blocking puberty is an answer to the problem. We know from Zucker's study that puberty was part of the solution, not part of the problem. So if we block puberty, we are taking away an enormously important physiologic stage of human development, where the brain patterns itself and neural pathways mature, organ systems mature to create a fertile human being, and all of that is eliminated by the use of puberty blockers at the beginning of puberty. The puberty blockers are very valid tools that we use in the endocrine world to stop children who have precocious puberty. We're talking about 5- and 6-year-old boys and girls who enter puberty at that age and would progress to full maturation in the course of 3 or 4 years and be profoundly short and also menstruating in 2nd grade, 3rd grade, which is a very big social issue for a young child to have to deal with. So we have used the puberty blockers in pediatric endocrinology to save these children and to put them on hold until their age is appropriate, and we recover a reasonable amount of final height potential, and we save them from having to mature early and have to deal with the social aspects of early maturation, which are considerable for those children. But we don't keep going, and we're doing it at a time when the body is otherwise, and the brain is otherwise not expecting to see the hormones of puberty. But it's a very limited course. It is reversible when it's done this way. It has no adverse long-term outcome from its use. And it's a very wonderful, exquisite way that has been developed to take care of this particular problem. In adults who have severe cancer that is estrogen dependent or testosterone dependent, these puberty blockers are used as well to shut down the pathway between the pituitary gland and the gonads to essentially save the person's life from an inevitable return of these hormone-dependent tumors. So it's a very different population, and there's a risk associated with that that has been well established and chronicled in terms of causing some issues with long-term health that raise a concern in the medical literature. So at age 16, the guidelines suggested that the puberty blockers be supplemented then with cross-sex hormones. So the boys who believed they were girls would be blocked and then be given estrogen at age 16. Likewise, the girls who thought they were boys would be blocked and given testosterone at age 16. So those were the guidelines. At age 18, if the patient desired, they could offer what they called corrective surgery. Corrective is sort of a strange term here. Of the 22 guidelines that the Endocrine Society wrote out and supported, only 3 were actually based on moderate amount of scientific evidence. There's a system called, they have an acronym for it, GRADE, G-R-A-D-E, and it is a system of 0 to 4 circles that are filled in, And 4 circles means that this particular recommendation is based on sound, reproducible science. 3 means there is some evidence in the literature, but not a lot, that this is possibly a valid recommendation. 2 stars means that there's a limited amount of evidence that is not compelling, and 1 means there's absolutely no evidence at all in scientific literature to support the recommendation. Despite grading this, only 3 of the recommendations were based on a moderate amount of science, and they were all the ones that were essentially the effects of puberty blockers in adults and cross-sex hormone therapy that had been researched in the literature at that time. The other 19 of them were half and half, either almost no science or absolutely no science to make the recommendations. This is a professional society in the United States making recommendations that were essentially a rubber stamp of the WPATH guidelines, written by the WPATH and essentially patched in to this committee. And so we have an organization which we should respect, making recommendations that are based on absolutely horrible science. So they were revised, and they actually asked for input on the revision, and I dutifully, along with about 4 of my other colleagues across the country, wrote very specific individual letters. It wasn't a letter we all signed. It was not a carbon copy with paste and send a letter in. It was a handwritten letter specifically addressing our own individual concerns. The Endocrine Society received my letter and did not acknowledge receipt of it. I sent it certified mail, so I knew it arrived on time. But they essentially, all 4 of us received absolutely no response other than a telephone response to one of us, and the recommendation was, well, thanks for bringing these things up. We'll sort of consider it next time we make a recommendation. And the changes that were recommended in the wording were not included in the revised guidelines in 2017. So it was just an exercise in futility. So added additional concerns about the need to counsel the patients about expected infertility were added to the 2017 guidelines. It's the only difference in terms of a new recommendation. So you have to counsel your teenage patient or your 6-year-old child that they're going to be infertile. How many 7-year-olds, 12-year-olds, 15-year-olds can wrap their head around permanent infertility and accept that and consent to that? It's a question that needs to be asked. They also suggested earlier cross-sex hormone therapy instead of waiting to 16. How about if you do maybe 14? And they also suggested what they call top surgery at an early age. Instead of waiting to 18, girls can have bilateral mastectomies now at age 16 by recommendation of the Endocrine Society. Again, it was exactly the same as on the prior iteration of these guidelines. Then all but 4 of these had scientific basis for their recommendations. And in addition, they too removed all references by Zucker, and they specifically did not reference Paul McHugh's epic paper that he wrote on the subject, which was referenced beautifully. It's a treatise that's really hard to get into because it is so detailed and so thorough and so well written. They also ignored our concerns. So the New Atlantis was where Dr. Lewis Mayer and Paul McHugh published their study, their review of the whole thing. This is very interesting. Paul McHugh had written this paper, and he said, I do not want it to be viewed as coming from an ideologue. You know, he was a devoutly faithful person in terms of his religious faith, and he said, if I write this, he said, first of all, it will not be accepted anywhere. And on top of that, the critics will say it's my religious ideology that drove me to come to the conclusions that I reach. So his colleague was an ethicist, Lawrence Mayer, and he happened to be there at Johns Hopkins doing a research project, and he also himself was a very strong proponent of the lesbian, gay, bisexual community. And Paul McHugh said, would you take this paper that I've written and would you tear it from limb to limb to be sure that what's in here does not show my own personal bias? And Lawrence Mayer said, sure, I'll be happy to do that for you. Lawrence Mayer read the paper and got into it and was profoundly blown away by the exquisite nature of the scientific research and the referencing and the insight that his paper. So he took it upon himself to write a foreword and take credit as the first author of the paper, so that the criticism against it would not come from the LGBT activist community as just ad hominem attacks saying that it was done by a religious right zealot. That didn't help any, because the activist community came after it anyway. Within a week of this, and they call this a study that was not published in a journal of any prestige at all, certainly not peer-reviewed, therefore worthless. And all you need to do is read this, and you understand the depth and breadth of the excellence of academic proportions. The paper on the right is Kenneth Zucker's paper in the Journal of Homosexuality, which is his review and reference of his 560 patients and the evaluation of those patients and the means to treat them and the success. So, not to be left out, in our country, guidelines were developed by the Paediatric Endocrine Society, of which I'm a member. It's an emphatic restatement of the 2017 Endocrine Society Guidelines. Again, they went through the pretense of asking for suggestions and they, again, ignored them. And essentially, the regulations call for transgender medical care and surgical treatments to be a covered service by insurance, and that was their additional comment in their guidelines. So we are essentially being bullnosed into this concept that these are the scientifically proven, and scientific community approves and agrees with these concepts, and it's not based on the membership. And you wonder how in the world can a professional organization of any size and reputation suddenly wrap themselves around these recommendations and somehow accept them. Well, the way it works is there's a general membership. In the case of the American Academy of Pediatrics, it's 66,000 members. They are sitting out there paying their dues, getting CME credit for courses that are offered, working with the credentialing groups. They form a special interest group as members of the Academy, and this is what happened with the Transgender Special Interest Group. The Executive Committee then works with the Special Interest Group and says, okay, Special Interest Group, you're the ones that are making the loudest noise. How about if you go ahead and put your thoughts down on paper, and we'll review it at the Executive Committee. So they talk to each other, and the Executive Committee, which in the case of the American Academy of Pediatrics is 12 individuals. They are the district chairman of their regions. They come up and they then recommend the guidelines, and the next thing you know, the general membership suddenly is in line with the special interest group. Does the membership know anything about this? In the case of the American Academy of Pediatrics, they do not. The policy statements are written by the special interest group. The executive committee, which has a particular political agenda, approves them for the entire organization. And it looks pretty impressive when you have the biggest professional group of pediatric physicians in the United States coming out with recommendations that transgender health should be treated according to the Endocrine Society Guidelines. But that's how it happens. So you see the American Psychological Association and their committee, their executive committee of about 30 people, speaks for the entire membership. Contrary opinions are not welcome. They make a decision and put out a policy statement. The next thing, the American Academy of Pediatrics falls in line, and then boom, the Endocrine Society falls in line, et cetera, et cetera, et cetera. So I represent the American College of Pediatricians, which is a very much smaller professional group. We base everything on published science, and our guidelines are, we are going to prove that what we recommend is absolutely, unequivocally, the best possible care for children. And it addresses that need at the expense of the wants and needs of the adults in the environment, either the parents or the medical community. So the purpose of the American College of Pediatricians is to get science back in the driver's seat and to not be trumped by the political influences. So we have the lesbian, gay, bisexual community, which has a very strong lobby. They have social support. They have financial support. They firmly believe in what they believe in, and they have the perfect right to do that. There are exceptionally fine outcomes that come from their lobbying efforts in terms of treatment and personal rights and whatnot, and quality of health care. All of a sudden, we've stuck the T on there, okay? Now, what does T stand for? Well, it depends. Transsexual is what John Money termed. Transgender is the current iteration of that term. Transvestite. Transvestites are heterosexual males and drag queens. They do not profess to be gay or transgender. So it is a purely social thing, but all of that is under the T, and when you add all these diverse populations together, it makes a little bit bigger group, and it includes the resources of the LGB community and the money and the everything in, and draws transgender in as if it is just as valid as the rest of the theories that govern lifestyles and health. So here is a famous transgender person from Georgia, RuPaul, whose name is Andre Charles. And when asked what he is, he says, "I'm a male," or "You can call me a female," or whatever he refers to himself as a he. And so he's not transgender, and yet the transgender activists use him as a cause célèbre, showing that he is a valid person with a valid diagnosis. So there's so much that is just on the surface so invalid about what they do, but it gains the attention in the media and the press and in the social circles and becomes essentially a civil rights issue in the United States. So it's an attempt to legitimize that transgenderism, or patients are born that way. Not a single shred of scientific evidence can be found, and believe you me, the activist community has been working through the National Institutes of Health and the Human Genome Project to try to find any level of codon missense mutations or physiologic changes biochemically that would identify somebody as either transgender or same-sex attracted, and they can't find anything. And the leaders of those groups have come out and stated, as was stated in McHugh and Mayer's paper, there is no biologic basis for transgenderism. Period. End of sentence. Now, the problem is that in the internet and its accessibility to teenagers, it provides a ripe opportunity for unhappy, depressed, anxious kids to find a resource that explains to them why they are miserable. And the idea of gender dysphoria being caused by their innate feeling of being born in the wrong body completely obliterates the concept that their concept of being born in the wrong body is most likely and is most frequently found to be the result of some significant adverse childhood events, such as parental divorce, okay, sexual abuse, death of a friend, death of a loved one in the family. Whether or not the family is functional or not, all of these things add up, and the concept of the child being born into the wrong sex becomes an answer that this is what makes it all better. This explains everything. So it's a very accessible thing on the internet. It's very scary. There are YouTube videos of young girls with very significant X-shaped scars where their breasts used to be, and they are very proud to display themselves on the internet and say, "I'm now happy. I'm the person I was meant to be." And it's infectious. It's almost as if it's a cult kind of experience. So they recruit new victims. Now, treatment of transgenderism essentially is creating a lifelong medical problem. Even if you believe you know what you're doing is correct, you are making these patients medically dependent in a way that they never would have been if you had left them well enough alone and done the counseling, okay? So it's beyond comprehension that the ethics of medical practice would allow us to use these kinds of guidelines and harm these patients irreparably. The U.S. landscape from 1970, the Transgender Clinic was established, as I said, 84. It was closed. 2006, Dr. Norman Spack comes back from the Netherlands, opens his clinic. 2009, the Endocrine Society Guidelines were published. In 2014, there were over 45 transgender clinics established in the United States at pediatric academic centers, and there are even more today. These are all in response to the need to meet this fantastically new, exciting medical condition and to provide the world's best treatment for it. So we have these clinics, all of whom ostensibly are run by experts in the field who are trained and certified, and there is no such training and no such certification. So there's been an experience of over a tenfold increase in referrals in the past 2 years in my clinical experience. So we have these clinics popping up like mushrooms across the country. The U.S. News and World Report magazine in the United States is viewed as the established place to make yourself known as a quality hospital, children's healthcare system. And they grade a number of healthcare systems every year in one of their issues. And our pediatric hospital system in Atlanta, Children's Healthcare of Atlanta, is obsessed with getting themselves a higher and higher position in these gradings that are given out. And so one of the grades that you get, and you get points for, is having an established transgender clinic that is growing in scope. And if you have that, you get extra points, and you go up on the scale of things. So the incentive to do this is perverse, and it carries on in ways that we have never dreamed that it should have. So the battle to return to science, which is what I stand for. Only gender-affirming experts are invited to speak at academic meetings. It makes it very difficult. I am not invited to any national society meetings to speak on the subject. I was supposed to be part of a recommendation committee for a balanced approach to have pro-affirmation and Kenneth Zucker's plan as the opposite opportunity or opposite alternative. And I was supposed to be part of that meeting, and the meeting went on, and it was only the one side. So it's the administrative branches of these things that put meetings together will not allow us to speak. I was told that I needed to go to that meeting and at the end of the presentation raise my hand and object from the floor. And that would be a balanced presentation, and the answer to that is no, it isn't. That's not how academic meetings work. Counseling to return to natal sex identity is outlawed in some states in the United States, and as was referenced here, may be outlawed in Australia. LGBT activists seek to destroy the opposition through academic influence. The academic faculty are afraid to open their mouths and say anything for fear that if they're not tenured, they will be toast. They've suspended or removed faculty with opposing views. They push the opposition underground. And the major medical journals, as evidenced by McHugh's paper, will not publish anything that is not under the mantra of this new theory. Research is designed to prove the benefits of affirmation with completely different standards. I've been involved in clinical research in patients almost all of my medical life. And the committees to protect human subjects develop the guidelines which we have to adhere to. And every time we are involved in a study from a pharmaceutical company, that company says to us, you must take a course in ethical clinical practice for clinical research in human subjects. Even though we've done this and we follow the guidelines, we have to take certification and testing and prove that we understand these guidelines. These guidelines say essentially that research subjects will be told every possible adverse outcome. And if there are outcomes that are more adverse than the benefits, the study will be shut down by an externally devised safety committee that has no financial or academic relationship to the researchers. So this is the standard of how research is to be done. In the United States, the National Institutes of Health has funded a 4-center study, Los Angeles, Chicago, Boston, and Seattle, and they are taking 5-year-old children and putting them through affirmation therapy. They have no other arm. They have no control arm at all. As they said, well, why would we have a control arm? These children are going to kill themselves if we don't do this, so we don't need a control arm. Now, the concept that you do something because a child threatens the possibility of suicide is blackmail, okay, so in my worldview. Seriously, if somebody is that suicidal and it is valid, you as a behavioral specialist will know that. But if a teenage child says to their parents, I want you to buy me a BMW, and if you don't do that, I will commit suicide. How many of you in this room would go out immediately to a car dealership, your entire life to spend money to pay for that child's BMW so that they will not kill themselves? It's insanity to think that way. And yet we are using the threat of suicide as the means to justify affirming these kids. Okay, so it's just the concepts of a persistent, insistent, and consistent desire to be the opposite sex applies to, if you apply that to any other kind of behavioral aspect of childhood, you'd be laughed out of here. If a child says, I want to be naked and I want to poop and pee all over the place, and I'm consistent and I'm persistent and insistent, we would not accept that as a social norm. But in the case of transgender medicine, we use that as the mantra of the things you have to say in order to be affirmed. So ethical guidelines need to be with informed consent. Now, how can a 7-year-old child who is struggling with figuring out what is reality and what is not as a part of normal childhood, and Piaget's whole theory of child development, which stands the test of time, you're going to affirm a fantasy. And what that does is causes development of severe anxiety because the child has no idea what is real and what is not real and fears that which he does not understand the rest of his life. So informed consent, you can't get informed consent from a child under the age of 18, legally in the United States. How are you going to have them make the changes and acquiesce and take hormones and have surgical correction for something that is not it's a delusional state? Clear assessment of benefit versus harm, absence of bias. The concept of a balanced presentation means that you look at the adverse side as well as the benefit side, and you weigh the two and you come up with a decision to proceed or not to proceed with the treatment. And then, as I said, independent assessment of safety is the hallmark of our ethical guidelines for medicine, and those have essentially been thrown out in the case of the NIH study. So it's a 5-year study of the benefits of affirmation in children age 5 and older. At the end of those 5 years, what do? They ask the child and his family if they're happy. They don't have an independent person who does not know whether or not this is an affirmed child or a counseled child in terms of returning like Kenneth Zucker did. There's no control group. How can you not come up with an answer that you wished to see in the first place? The study is designed specifically to prove that affirmation is healthy and beneficial. There, as I said, there's no control group. They said, well, we'll use the siblings of the patients as the control group. And as I said, the evaluation of success is by parents and the transgender clinic staff. Details are unavailable on the website. There is a movement to go through the Freedom of Information Act in the United States and uncover all of the nefarious background of how this made it to the university institutional review boards and how it can possibly be carried on. Fallout in local communities, school boards are railroading through regulations without public hearings. In the city of Decatur, Georgia, which is a suburb of Atlanta, I had a chance to speak in front of the school board, who had already decided that they were going to put into place the regulation that bathrooms and locker rooms were going to be whatever the child wanted to be, and that would be the new school regulation. It was done without a hearing. The parents sued. They created a hearing. They already had their opinion behind them, and they were going to push the regulations, but all of a sudden it disappeared from the radar screen because one of the transgendered boys, a boy who wanted to be a girl, sexually assaulted another girl in the locker room at school. So suddenly they've dropped everything as if none of this ever happened. So, I mean, it's a shame that that had to happen to a child in that school. Both children, both the offender and the ones that were offended by his action. Large corporations are threatening to pull out of municipalities. Our lovely Atlanta professional sports teams have a very specific affirmation of transgender identity that's shown up on all of the video screens at the beginning of every professional sports game. Gender centers of excellence are actively treating patients now from age 3 and older, despite no scientific evidence of what they're doing. So what can we do to return to sanity? Always begin with a statement that truly shows your compassion for the suffering individuals. Every single patient that comes to my office, I establish that they are my client, that the parents are secondary and important in helping with therapeutic interventions, but that my job is to alleviate the suffering of the child, and that in my own personal and ethical and professional opinion, I will not harm the child by blocking puberty or using cross-sex hormones. And my patient population overall goes all the way up through the first graduate degree, undergraduate degree in college. So I have kids that are past the age of consent. And if they came to me and asked my opinion, I would tell them exactly the same thing, even though they can consent to that I would fear that they would bring themselves ultimate harm and damage. And I couldn't personally be responsible for any part of that I would keep them, and I would find a counselor that would do what Kenneth Zucker did and all of his hard work to bring this patient back to a stable mental health circumstance. So we stand firm with our scientifically based conviction, and we invite dialogue. It's the hardest thing to do because nobody on the other side wants to talk. They're not interested at all in having dialogue. We wanted to join a broad-based group of diverse backgrounds. The radical feminist groups are very interested in stopping the transgender nonsense because essentially it says there is no reason to be female. There is nothing unique about female. Females have no specific roles. You can be anything you want to be. It's very, very threatening. Never be afraid to weave your faith into the discussion. I did a radio interview on a Christian radio station here in Australia last week with some callers. And I was asked point blank, do you use your religious faith in your medical practice? I can't help but use my faith. But it does not make me push decisions on people who have a different or diverse faith. What it makes me do is to be ethical and to review everything I do based on my own structure of faith. And it's, my example is set an example of who you wish to be and what you think that your God wants of you. And if you do that's an evangelization in and of itself. So I don't stand out on street corners and thump a Bible. That's not who I am personally, but I know what I should do, and I use it in my medical practice pretty much every single day. This is a book written by Renee Jacks, who is a man who struggled with gender identity disorder for a number of years, and finally at age 35 had cross-sex hormone therapy, and a couple of years later had the surgical removal of his penis and scrotum and had a vaginal orifice created. He, and he doesn't mind being called either, wrote this book, Don't Get on the Plane, Reasons to Reconsider Your Sex Change. And if you look at the label on the plane, it's Trans World Airlines. For those of you who are my age who remember that airline as it truly did exist. It's kind of poignant. So it's high time, and I'll end with this point, is that we need to point out that indeed the emperor is naked. Thank you for your time.